Okay, thank you so much, Chairman. It's my great honor to give a talk in the İzmir Online Neurosurgery. Uh, this time, my speak talk title will be Transforaminal Discectomy for Mobile Outside-in Technique. This is my curriculum by 10 disclosure. This today content of speaking, talking. I know that İzmir is very beautiful place in Turkey, and I visited there. This is very unforgettable memory for me. Yes, we know that some endoscopic spine surgery now developed so much, and now we going on the process of the first generation of transforaminal discectomy, and second generation of the intraoperative discectomy, and third generation of endoscopic decompression, and now going on the fusion and another extraordinary expansion of the endoscopic spine surgery, spinoscopic spine surgery for the spinal treatment. Among them, we know that the basics and the purse of the endoscopic, spinoscopic spinal surgery started from the transfemoral approach because of that the to learn and to performing will be very important portion of the endoscopic treatment. Yes, in the especially we know that spinoscopic or endoscopic spine surgery. Most two important point is that we because we should overcome the obstacles of the body structures, and we should overcome the some damage of the nerve. We there have a two important point will be first how to we make a mobilization of the working channel, and second things how to making the sufficient working space. In the transfer approach, first will be the mobilization of the working channel to the target point, especially in because of that. I think that this mobile outside in technique is some different compared to the conventional open transforaminal discectomy. You can see here, I already published this paper in 2018 in Journal of Visualized Experiment by me, and outside in mobile outside in technique, and you can see here that these figures, and also second very important point of the transformer approach. I already mentioned that how to making the sufficient working space, because of that transformer are always not sufficient to the operate to the target point, because of the making the sufficient working space will be very important portion to success the transfemoral discectomy. Among them, this in the transfemoral approach, we can easily overcome this problem by the femorectomy. Using this femorectomy, you can see like highly inflammatory cases, highly supraminal cases also can easily overcome using these techniques. Firstly, we share some very beautiful photos from taken by me. I love this photo so much. And anyway, first we'll be thinking about it, why we should every time some remind that some purse and concept of transformer approach. I will show some cases you can see here. I will show some several kind of degenerative disc cases. You can see here that this patient also um, huge central high canal compromised cases. If we make this, in spite of this patient so high grade degeneration, high canal compromise, because of that, if we performing the good treatment to the patient finally will fail his return to normal life. Sometimes they need some fusion surgery, and sometimes some malfunction of his life. Because of that, we hope to every surgeon, every spine surgeon, every endoscope surgeon I think that hope to make like this figure. You look here. This patient is this image is not a normal image. This image first starting from this image because of that. Some finding some taking the good treatment is a real purpose to the patient to return to his normal life. And also, like this case is also you can see the highly inferior migrate cases. Yes, we know that like this highly inferior migrate cases before we remove the disc pathology and some and combined with some discectomy together. But we, as a, I already mentioned, that as a spine surgeon, as a doctor, we hope to give a more good treatment to the patient, and we hope to more preserve the patient function. We hope to more. The patient to return to normal life. Because of that, we hope to only remove this pathology not damage to another structures like this. And also, this case is also similar to the severe primary disk with a highly superior migrated cases also. In this case is not only damage the discal area, but also that related to the dorsal ganglion, and but also related to the facet area because of that. If we uh, hope to remove disc sufficiently, sometimes in the sufficient facets damage may be needed. Because of that, some doctors choose the fusion surgery. But if we can give the success like this and preserve the oral structures and only pathology this can remove that, the patient that really have a chance to their return to normal life. And also, this case is already received the open laminectomy, and but unfortunately have some recurred cases. Also, we know that in these cases also before this is not easy uh, pathology because of that. If we try the open surgery, maybe need some adhesion and sometimes nerve damage and sometimes incomplete surgery. But any patient, any doctors, we hope to the patient to take only this pathology, and we hope to the patient, the doctor all hope to preserve the all structures completely and hope to return to normal life. I believe that it can really possible by the mobile outside technique. And also, more seriously, you can see that this patient, only 10-year old male patient, have some Kodai-Kina syndrome. And maybe if we met like this patient, maybe the patient, in spite of the young patient, because of the due to the severe neurologic status, the patient maybe the surgeon maybe choose the fusion surgery or some wide decompression for the overcome the patient pending neurologic status. But if we performing this process by the transforaminally remove this pathology and preserve all structures, I will believe that these young people's life completely changed his life quality, remain the lifespan. But if we not possible uh, performing transformer like this sufficiently, the patient maybe some not good life will take. But now because we checking the historical review of the transforaminal discectomy, we already well known that some firstly this concept started from Dr. Parvich Cambin, firstly introducing the Cambin's triangle 1986. We always some honor to starting this very amazing, very meaningful trans-Cambian triangle. But unfortunately, before 21st century, this uh, transfemoral approach in not only is possible only non-visualized procedures because of that time this approach is not incomplete surgery. in so many cases. But we know that uh, this legendary of the Tony Young firstly introducing the visualized inside-out technique, and his innovative technique gave some new a life to the patient of the degenerative spinal this is especially lumbar disc pathology, and I always some respect to his great work. And but anyway, using this inside out transforaminal approach, but some of cases not easy to overcome transforaminal approaches. Some of this pathology to overcome this problem. Thomas Hoagland introducing the outside in technique. This outside in technique basically based on the foraminotomy, blind procedures of foraminotomy. Because of that, after introducing the outside-in technique, the this transforaminal approach developed more much. But anyway, uh, because of that, transforaminal area always some blocking and that. Uh, of the mobilization due to the some bone structures. In spite of the outside in technique introducing, some of cases not easy to overcome the obstacles, overcome the some limitation to the target point. Because of that, I introducing the outside in technique, mobile outside in technique in general visualized experience 2018. Today, I'm talking about these procedures. This photo shows a beautiful Antalya photos taken by me in 2014 in HMIST. I love this photo so much. This Antalya is a very beautiful place also. Yeah, now we checking about the transformer approach. Firstly, we know that in the transformer approach, the docking is the first most important point is that to the canvas triangle to successful docking into the target point, we know that the sufficient insertion point. There have three skin marking method introducing in the field. We know that already the basic the first method, you know that already measured method of alpha 5 12 centimeter, L3 for 10 centimeter from the midline, and L3 for about 8 centimeter, above L2 3 about 6 centimeter. But this sometimes it changes by the patient body height and body weight and the the body mass. Because of that, is sometimes fault. Because of that, some doctors use using the some marking method, but this is not easy in the procedures. But because of that, I use the manual checking method. There is some different. You can see like this. Basics is that I checking the lateral border of the iliac crest and drawing the oblique line. There is this line, meaning the back muscle and abdominal muscle boundary. Then always incise the some 1 centimeter from medial this incise line, oblique line. You can see here like this. Firstly, checking the back muscle and then checking the abdominal muscle, then draw insert through this area. And always and also we know that using this method, it always insert about 25 or 30 degree from the posterior to Kempin's triangle. Because of that, sometimes that is not easy to the target point. Because of that, I use the mobile outside-in technique. But you know that this technique is very safe in the 2 point. One point is that there's some visceral injury. The second point is more important thing is that some it very safe from the dorsal ganglion damage. Because of that, some doctors they try the more less angled approach to the target point to approach to the target point, but sometimes it makes us some 도살로 ganglion damage, then post-operative dysesthesia, post-operative weakness maybe happen. But if we use this technique, that problem usually not happen. And then we know that the two anyway, if after skin scan, the second step will insert a working channel to the canvas triangle, and then we know that the most important thing is that the insert to the safety point. Most safety point will be the lowest and more those are part of this canvas triangle to here. In the X-ray, you can see like this shape. And also, to uh, to knowing that some performing the mobile outside insufficiently, we should knowing that some sufficient very important anatomy of the suprapedicular notch. Uh, I also write in this paper suprapedicular approach to uh, 2009 in JKNS, and you can see here is the suprapedicular notch, and to exposing this suprapedicular notch it will be the very important surgical steps of highly inferior migrated cases, and also to open the epidural space sufficiently in the cases of the high canal compromised cases. And in the 2009, my paper showing that this suprapedicular notch area, after exposing this area, we can more sufficiently limit the highly inferior migrate cases like this way. Now we talking about that mobile outside in approach. This photo taken from the Istanbul, a very beautiful Istanbul river. Uh, I taken this photo in 2017 to FNS. Yeah, you know that in the transcambin area usually have a two shaped of the two volume of a chemist triangle. We at the beginner usually knowing that this larger chemist triangle, but we to success the mobile outside technique, we should knowing that this small canvas triangle because of that we should docking this area and then mobilize the working channel from here, then move to the target point. Because of that, knowing this anatomy will be very important. We hope to, I already mentioned that in the conventional posterolateral transforaminal approach, you usually make a 25-degree or 30-degree. Because of that, this is very safe from the visceral injury and dorsal ganglion injury. Anyway, this angle is very not easy to approach to the target point. Because of that, sometimes it needs some foraminotomy. Anyway, I already mentioned that this knowing this anatomy very important. In intraoperatively, we see this configuration. Understanding this configuration also some tips to some uh, learning the outside and over the outside mobile outside in technique. You can see after deeply docking the working channel to the canvas triangle, you can see this configuration of the foraminal ligament and fats. And after clearing using the radio frequency, you can see the disc epidural space, and this foraminal area, this pedicle area. Knowing this anatomy will be very important in mobile outside-in technique. Then we inserted the working channel like uh, I already mentioned that if they have knowledge to the target point, sometimes we making the parametromy. This parametromy also very important steps in the uh, mobile outside-in technique. Some doctors using the some blind procedures. Some I use the always using diamond bore drill, and then uh, yeah. And also to understanding the mobile outside in technique, we should know some another anatomical structures of three different routes of the trans uh, foraminal area. This paper also published in World Neurosurgery and 2017. Here, I mentioned that there have in the transforaminal area there have three different routes: intervertebral root here and foraminal root here. Here, this like foraminal shape of this foraminal root, and this suprapedicular root here. Sorry, sorry, it slide some blocking. Okay. Suprapedicular root here. Because of that, the understanding this anatomy also very important to performing the mobile outside procedures. You can see this configuration in the World Neurosurgery, my paper. And using this, understanding these three different routes, we can see that some disc pathology of paracentral to central disc or high canal compromise, we usually use the intervertebral route directly to here. But in the cases of the uh, paratraal, foraminal, and superior migrated disc, we use the foraminal route to like this way. But here have a neurological barrier of the dorsal root ganglion, and then because of that, the true self retraction of this dorsal root ganglion will be the point of the success of this foraminal route approach. In the foreign route approach, 2 points will be very important to success. First step is protect the dorsal root ganglion. Second point, sufficiently approach to the foraminal area using the large walking channel. That we're using the riding technique I will introducing after that. And then third route will be the suprapedicular route. Third route is the suprapedicular route using the paracentral disc, central disc, and inferior migrate disc here. But we in this area, this suprapedicular route have a big barrier, of the anatomical barrier of the bony structures, and also I already mentioned that the suprapedicular notch in exposing that some success point of this pedicle root approach, and then to cut the resection of this area can make a sufficient space to operate to the target point. And then we can possible to after approach like this way. And then here in the intervertebral route after approach, most important point will be the making the sufficient uh, walking space, especially exposing the epidural space. You can see. Fortunately, some of patients can without parametromy can make some half of epidural space can exposing is possible, but mostly after space is not exposed. Because of that, intervertebral route to successful mobile outside in approach, the parametromy using the some blind procedures, using the some drilling diamond drill, that will be a very important step to success these procedures. And in the primary route, existing route approach, I already mentioned that we can approach to here like this way. But this area, two obstacle is that some dorsal root ganglion protection, and then second point is that how to approach to larger working channel to that space. But I already mentioned that using the working channel traction that the dorsal root ganglion protection can possible, and using the vertebral riding technique approach to the target point also can possible. Then we can approach to the axillary area like this way. And also in the suprapedicular route, there have obstacles of the bone structures because of that. Exposing the suprapedicular route is the first step. Then we can going to like this way using the foramectomy. Then we can now really can possible mobile outsiding technique like this way, some foraminal and this this suprapedicular approach can possible. And here you can see the some how to mobilize the deep Campbell's triangle. And then now we checking the point of the success of the this mobile outside technique. I already mentioned that the intervertebral route we approach to like this way, but mostly they'll have exposing the epidural space is a very important portion. But Dr. Lee writing the paper half and half technique, but some patients they're also not easy because of that. Many doctors they need some parametry using the blind uh, procedures sometimes using like in my technique of drilling technique, then after half of after space exposure is possible. Then we hope you saw the I already mentioned that the conventional postural arthroplasty like this way because of that using the mobile outside in technique not inserted like this way but docking to here then to lessen the angle is possible because and then going to the more deeper point to using this lessen the angle in if the epidural space exposes status. But if there have no epidural space exposing state, we use the parameter like this way. And also, uh, here is sorry. Here I showing that showing that some primary route approach. I already mentioned that in the primary route approach, 2 points will be very important. One is uh, protecting the dorsal root ganglion, and second point is that how to approach to this area. I always using the vertebral riding technique. You can see here firstly docking the disc space in the vertebral area, then rotate and change the angle and rotate, change the angle again and rotate, change the angle again. Then then expose the foraminal root area. In the highly inferior migrate cases, I already mentioned that exposing this suprapedicular notch will be the first step. Then we can drilling this area. I'm also writing the paper of the Scott technique, suprapedicular circumferential initial opening technique in Biomed Research International. You can see here this my technique of circumferential opening area, this suprapedicular Dutch area. In the highly inferior migrate cases, anyway, exposing the suprapedicular notch and opening this area and will be most important step. Sometimes it maybe need only some uh, pediculotomy is sufficient. Sometimes in the vertebral drilling, maybe some needed. And then after that, we knowing this knowledge, we can now can possible foraminal root is possible, and intervertebral root approach is possible, and suprapedicular root approach is possible. Then mobile outside in technique really can possible. Now we see the video in the Journal of Visualized experiment here. Now push the operator to the deep canvas triangle. I already mentioned that the insert the object to more deep canvas triangle will be very important. Sorry, and also I always docking my working channel to this canvas triangle, not insert to the disk space, not in open the foraminectomy still. But after they are needed some foraminectomy at the time, I'm using the endoscope drill foraminectomy then processing. You can see the mobilize the working channel because of that. This working channel not insert to the some blocking space, some this intervertebral area, some more deeper foraminal area. Because of that, I can mobilize the working channel to the target point is possible. Meaning that in spite of the disk space already exposed and cutting already done there, I still not inserted working channel to the disk space, so still canvas triangle, and then meaning that the still possible mobilization of the working channel to the target point. You can see here, yeah. Yes, finally review this procedures using the case. Okay. Firstly, you can see the 49-year-old male patient with a high canal compromise cases. Fortunately, this patient have a wide foraminal space because of that. This patient not needed foraminal. But I already mentioned that exposing the epidural space is very important, and also you can see that not insert the working channel to the disc space or still mobilize the working channel. You can see the exposing the epidural space, then possible like this, and also this case is a 20-year-old male patient, and I'm already mentioned that. But this patient is a very, very severe high canal compromised disc with Kodaikina syndrome. Because of that, in spite of the young patient, this patient need a parameter to exposing the actual space sufficiently. But I'm always not insert the working channel to the disc space. Always mobilize docking the walking channel to canvas triangle. Sorry. Okay. Firstly, performing the drilling. You can see here the walking channel not insert to the disk space. Then, uh, after then, you can see the patient have a excellent clinical result. This another case is high canal compromise, the foot drop patient. The patient also using the mobile outside-in technique, very huge disc cases. This walking channel docking to the canvas triangle, then expose the abdominal space here. And after then, lessen the walking channel, lessen the angle, and I approach the more dorsal point. I'm checking more dorsal point. Walking channel still uh, can outside in this area. Then after then, the patient foot drop recovered 3 months later completely. Now we before we see the some intervertebral approach, now we will see the foraminal root approach. Here you should checking the 2 point. One point how to protect the kicking nerve root, and the second point is the how to approach to the target point. I already mentioned that some using the working channel rotation, and change the angle, uh, vertebral overriding technique. Firstly, protect the dorsal ganglion here, rupture disc. Here, vertebral foraminal area, vertebral space. Here, still some intervertebral area, not overriding. Rotation, the walking channel, operate to the axilla area. After then, you can see like this way. Um, Here, another case is highly superior migrate cases and combined high canal compromised cases together. You can see here the firstly docking the working channel canvas triangle and drilling in the foraminal superior facet area, superior articular process. Here now intervertebral disc space, then cutting the foraminal area. But then needed some supraarticular process tip area, foraminal root area drilling. It looks like a foraminal area. This area, supraarticular notch area. It means that the cranial to caudal or checking. Here, before you saw the some vertebral body drilling. Finally, you can see the free. and postoperative. Yeah, now you can see the some L1 to foraminal highly superior migrate cases. Then, firstly, ducking um, like this shape here, and okay. Uh, Drilling, especially to the target, the SAP tip area, because of that, there is an approach point. Now, drilling of the SAP, you can see the foraminal area, some rupture disc. To approach it to this area, sometimes you need some sufficient SAP tip resection needed. Finally, we see the some free dorsal root ganglion and free uh, axilla area. Then after operation, uh, now we see the some how to approach to the suprapedicular approach. I already mentioned that exposing the suprapedicular notch is first step, and then it can possible to exposing that area using the endoscope drill. Now during the pedicle, so record cases of highly inferior migrate cases. You can see here there are sufficient Scott technique and free. Now checking the free after space. After then, like this. And some another cases, highly inferior migrate cases. Firstly, exposing the suprapedicular notch, then sometimes through the facet, pedicle, vertebral body. That is some Scott techniques, suprapedicular circumferential opening technique. Then you can see like this way. Finally, we checking the free, the root, and after operation like this. And after, yeah, after learning this mobile outside-in technique, you can perform more difficult cases. This case is 15-year or pars. Posterior apophyseal limb fracture, you can say, is a, or calcification of disc. This is very difficult before of the transforaminal open surgery, also not easy. Endoscope approach not easy, or operation is not easy because of the many doctors choose sometimes a fusion surgery. But this patient only 15 years. But if we possible transforaminally by the using the mobile outside technique, I will show it. Docking the working channel can be triangle and mobilize the working channel to the calcified disc area and cutting this calcified bone by the punchy and sometimes forceps. Then you can see this calcification. really can possible by the really advantages that some mobile outside in technique. If I have no technique of mobile as outside in technique, I'm also not possible in these cases. But then you can see like this. Yes. This case is showing the real advantage of the mobile outside in approach. This case is 30-year female patient with a huge rupture disc and severe back pain and both leg pain. And also you can see this right side and left side cranial, caudal, meaning that the right side upper, right side lower, left side upper, left side lower rupture disc or four corner rupture disc cases. How to overcome this problem using the mobile outside technique you can see here. Using the foraminotomy, firstly, I expose the working space sufficiently, and then docking the working channel, canvas triangle that insert to disk space, then mobilize the working channel to the target point. Firstly, remove the ipsilateral inferior. Now remove the ipsilateral superior, then go to the contralateral, contralateral inferior, and contralateral superior, checking all points. Then you can see the all area freed. And after operation, you can see the all disc removed completely. Using this 2 point of the mobile outside in and some sufficient parametromy, we can possible to approach more higher level. This case is T12L1 intradural rupture. This case is 15-year, 1 year old male patient. You can see here intradural and then partially uh, ducking the working channel facet area, then drilling the bony structures of facet area, then exposing the canvas triangle. Then you can see after sufficient parameter, you can see the some dura and severe adhesion point here, and then after disc drilling, sometimes I use the disc drilling in the thoracic area. Then you can select the shape. After clear this area, still severe adhesion, and you can see here the dural tear point. After then, you can see the intradural rupture disc here, and then I remove using the forceps with the mobile outside in angle. Then finally, you can see the spinal cord. After then, I patch it using the taco seal. Then after operation, the patient can take a successful clinical result. And also, this mobile outside in technique also can approach to the higher thoracic area. This T45 rupture these cases with the severe back pain and leg pain. I already mentioned that not insert to the working channel some disc space, only docking the facet area and after drilling, expose the canvas triangle, then mobilize the working channel to the target point. Then you can see like this after drilling of facet, after drilling of disc area, you can see the target point here. Then finally, you can see the free after space. And after operation, you can see the pathology removed successfully. I love this photo. This photo taken 2013. İzmir, Turkey, in İzmir. İzmir. Here you can see the Tony Young, Martin Knight, and Thomas Hoagland. I respect them. Uh, uh, I love this photo so much. Hear me. Yeah, in conclusion, in the technical tips of a mobile outside-in approach, we use the mobile mobilization of working channel will be very important point because of that working channel not inserted into the disk space, the docking to the canvas triangle, then we should understanding the three different routes and also making the sufficient working space like a foraminectomy we use the sufficient endoscope drill, and then finally we targeted to the target point. And then we can take a real goal of transforaminal endoscope lumbar discectomy of a real minimized option, less neural retraction, preserve the functional segment, preserve the neurologic stream, and return to normal life of patient. Thank you for your kind attention. I cannot understand. I
Okay.
cannot see you
I
talking.
am
Yeah,
trying to open my voice, Dr. Kim. Okay.
yeah,
Dr. Kim, thank you very much for your excellent presentation. And now I would
yeah,
like to relate the questions from our colleagues.
yeah.
There is one question. First of all, he's saying that thank you so much, this inspiring lecture. And do you use indigo carmine in every transforaminal case? That's the question.
Yeah, in the transfer approach, I always use the Indio Carmine, but in terminal cases, sometimes I'm not using it. Because of that, the internal case is more clearly and to the docking the working channel to the target point. But in the transformer area, the configuration of Jura and some disk will be very important to safely performing the procedures because of the, I always using the indiocarmine. But higher apoptosis is not non-using.
Uh, Thank you, Dr. Kim. Actually, there is no another question from audience, but I have two questions, and of course, I will use my privilege coming from my moderator position. So, Dr. Kim, as you know, in 2007, the Vorodil group introduced the half and half and epiduroscopic technique. Of course, I am familiar with your 2018 article on the mobile outside in technique. Since 2009, I have also been using the half and half technique in my practice. Now, if we summarize that, when the needle and cannula are placed precisely into the foramen, the upper half of the endoscopic view shows us epidural cavity, while the lower half shows the disc space. Huh? As we proceed, we can say that the working channel is never fixed. You are right. It constantly
Yeah.
shifts
Mm.
depending on the location of the herniation. It moves dynamically into the spinal canal in cases of intracanal or high compromised herniations. Toward the pedicle in downward migration, sometimes we are doing oblique pediculotomy or drilling of the dorsal surface of the vertebra, and you are calling it circumferential opening technique, and toward the axilla of the excipic nerve in upward migrations. My first question is, what is the main difference between the mobile outside in technique and the half and half technique? And my second question is, in cases of multi-fragmented migrations, what are the boundaries of the exposure area in the cranial or caudal directions? Thanks for your answer.
Yeah, thank you so much. I know that half and half technique. I also love the half and half technique before. But you know that that is very, very excellent and brilliant technique. But you know that that is basically inside out concept. Because of that, in spite of that, making the half and half, there is some mobilization of the working channel. Sometimes it's not easy. But and also uh, mobile outside technique, I already mentioned that that is not insert to the working channel to the disk area because of that always outside in disk annular area always. It means that the more easy to mobilize to the target point. Only problem is that some deeply docking, it will be very important to working channel not move to another danger point. Can you understand?
Yeah, of course. Thank you.
Yeah. And also your second question, like that, you saw the some huge lot of disc migrated from cranial to caudal cases. Sometimes uh, uh, I use in that cases I use the facet drilling from the caudal to cranial near all area. It means that the suprapedicular notch drilling and the SAP tip drilling together and the facet area drilling all together, then make a sufficient working space, then operate to cranial to caudal, transforaminal foraminal route, intervertebral route, and suprapedicular route simultaneously done doing.
Okay, thank you. And
Okay.
another question came from audience, Dr. Kim. This is the question. Many of your cases could also be done through an interlaminar approach. What is your criteria for choosing transforaminal technique? Also, you can read.
Yeah. Dear Alfonso Garcia, thank you so much for your question. But I already mentioned that the purpose and the concept, mind of the endoscopic spine surgery, I always starting from the transforaminal approach that preserving the all structure completely. Yeah, we know that the internal approach, they're also very nice approach, but anyway, that they have some cutting the ligament flavum, some making the some adhesion of the after operation. Because of that, if we possible, operate to the transformer will be give the more good preservation of the structures, if we possible, to the patient can preserve their structure near completely. Because of that, I'm not doing the L45 above the L45 level. I'm not doing the intraabdominal. In the disc cases, always transforaminal. Only L5 is intraabdominal doing. We mean that the above L45 level always in transforaminal approach in the disc pathology cases.
Yes, I agree with you. Also, I have one complaint about the surgical fashion. In last times, the young surgeons are going to interlaminar surgery so much. And I think that particularly in upper lumbar levels, it is so dangerous or it is unnecessary. And transforaminal surgery, really minimal invasive surgery. I agree with you. Uh, there is another question, sorry, you can read also. As I understand from your videos, you use endopunch to take out calcifications. Is that right? That's the question.
In the calcified this case, disc or calcified vertebral lumbar is not easy in the endoscopic approach. I use some techniques, three technique. One is some drilling technique. Many cases I'm drilling the calcified point, but in the cases of calcified disc, not easy to drill to there. In the cases I using the punchy, and in the some enlarge the vertebral body. Sometimes I using the some working channel rotation technique. There- Yeah.
I saw that there is no another question. And Dr. Kim, thank you once again for being our guest today. We sincerely hope to see you with us again in the future. Thanks again very much. And dear colleagues, thanks for your participation. And I am closing the session. Thank you very much, everyone.
Can I say
Thank you
one?
so much.
Sorry, Dr. Sujo. Sorry, I am very sorry.
Uh,
Dr. Hassan.
it's a great honor to have you again, third time in our conference.
Yeah.
And I want to say that Dr. Kim is a great teacher. I learned a lot from him. And also, he's a great man. I was a guest in his hospital, and he treated me a meal, dinner near the hospital. Thank you very much. And I expect you in İzmir. I hope to see you in İzmir.
Dr. Kamil, can I come here also?
Of
İzmir?
course, of course.
Thank you. Thank you.
We can have a dinner
Yeah,
with
yeah,
rugby and
Altogether.
fish.
Okay.
yeah, yeah. Thank you
Can
so
Dr.
much. Yeah, I hope so visit to İzmir again.
Thank you so much. Thank you.
There is Chesmi and İzmir, very beautiful place.
Yeah, yeah. You must come
Yeah,
again.
yeah.
Come again.
Yeah, thank you so much. Yeah.
Thank you. Thank you.
Okay.
Bye bye.
Bye bye, everyone.
Okay, thank you so much.
Thank you.
You're welcome.
Selin.
Closing the session.